a warm welcome to you. We have been on a long hiatus and we are just very happy to be back with you. And so welcome back to Advanced Practice. We hope that this session will relaunch us to be of help to you in these times of COVID. So I'm sure you remember the faces, but you'll remember Dr. John Higginbottom, whose brainchild this work is. So we're very grateful to him. Very grateful to Manny, who's on the line today, and Jen, who's done a lot of work to set us up this morning. And also dear Jordan Clark, who is the person who built this platform for us many years ago. And he is always around to support us. Well, we're very, very grateful to Jordan for his technical support as well. Yeah. And you'll remember that we were initially funded by the Ministry of Health and then through some grants through the Ministry of Skills, Training and Education. And much of this work happens honestly as a result of the kindness of our presenters who do this pro bono, this work, who share their expertise on best and promising and emerging practices. So we're very, very grateful to people who give up their time to help us to learn and to grow. And you'll remember that our focus is on really trying to consider how best we can transfer those the knowledge and the skills of best and emerging practices to help people receiving services have their best life. And so our team that's really our mission to do that. As Douglas College staff, we'd just like to acknowledge the Coquitlam and Pequot First Nations, as well as all Coast Salish peoples on whose traditional and unceded territory we live, learn, play, and work. After this, you'll receive an evaluation, a link for an evaluation. So we really do read all of those things and appreciate your feedback. A big part of that is also asking for your help for future presentations. So if you have a program that you wish to talk to us about, or you've heard a particularly good presentation, perhaps, we'd love to hear about it. And we really welcome presenters on a range of different topics. We are acknowledging that we have somewhat of a gap, perhaps, in looking at diversity, anti-racism, those kinds of emerging things that we would like to consider how even to sharpen our competencies and our indicators as PSR practitioners. So if you happen to have resources, individuals who might help us learn and grow in those areas, we'd particularly love to hear about that as well. So again, we're very grateful to our presenters and we're always looking for people to help stretch us and to help learn about what's happening across the country and across BC in particular. Yeah, so to that note, some upcoming presentations are, maybe you've seen on our psyrehab.ca website, we have an upcoming series on mindfulness. Currently, those spots are filled. But if you have an interest, if we have enough interest coming in, we may be able to consider how we may be able to repeat that. So that's 4 sessions that will bring us right through to January on mindfulness. And our intention with that is just listening to and understanding that many people who are delivering and receiving services are just kind of tired with all the COVID, and we're trying to really give back to our community a little bit and help our health and well-being by just supporting a little time of your day, hopefully once a week, to connect and to engage in some mindfulness. Also, there is talk in British Columbia of maybe in this spring having a virtual or hybrid conference on psychosocial rehabilitation. So we'll tell you more about that as time goes by. So again, if you have interest or you have particular topics you'd like to speak about or speak to us about, please do let us know. So we look forward to hearing from you. So with all of that planning and organizing and background, we are going to introduce our speakers today. So we're very grateful again to folks who have spent their morning with us today. And we'll begin with Lauren, who's an occupational therapist who provides mental health services for 18 years before transitioning to becoming the coordinator of Mental Wellness Day program. She's also a project lead on the Booster Buddy. If you haven't seen that, you might want to give it a look. It's a mobile app, and she's the co-chair of the Regional Island Health Committee on Recovery-Oriented Practice in Victoria, and I know they're doing some stellar work. Most recently, she and her team have transitioned to an in-person group-based psychosocial rehabilitation program to a virtual program in response to COVID-19 pandemic. So that's the work that we're going to hear about today, along with our co-presenters that include Kerry, who has worked over 15 years in mental health field, and she's worked on the inpatient psychiatry, facilitated CBT sessions in the community, presented at international conference in the area of nursing and therapy or counseling. And today we made her an honorary occupational therapy member, just saying. Anyways, most recently, she has been awarded a grant to explore best practices to support families when their loved ones are in hospital for mental health. So I think that's really amazing work, and thank you for that contribution, Kerry. Currently, she's a nurse recovery coach. Hopefully we'll hear more about that with mental health wellness program in Victoria, BC, and is thrilled to be on the cutting edge of healthcare delivery as virtual care gains further popularity within the public and care providers. We also have Nicole Heron, who's an occupational therapist who enjoys integrating both her mental health and physical medicine acute care experiences into a holistic approach. Nicole has explored innovative practice ideas, including leading a pilot PSR group in dance and movement, and has stepped up with curiosity to the world of virtual group programming. She's currently working on our cognitive behavioral therapy certification with the Canadian Association of Cognitive Behavioral Therapists. And then last but definitely not least, we have dear Doreen, who brings a wealth of lived experience to this webinar discussion. Determined not to let mental health issues hold her back, Doreen earned a university degree and is a professional writer, journalist, and visual artist. Her community activism to promote inclusion for people with mental health challenges and to dispel the harmful stigma was recognizing with a designation of finalist in the 2012 Victoria Leadership Awards. So with that, we turn you over first to Lauren, and there we go, over to Lauren, who will take us to the first.
Thank you so much for that introduction, Regina. Very much appreciated. I was going to conduct a poll to get a sense of who has joined us today and sort of what your perspective is and what your experiences are with virtual mental health care. And unfortunately, we couldn't quite figure out how to get the polling function working. So maybe we can explore that in a chat at the end when we have a question and answer time available to us. So I'm just going to leap right in to our presentation. And we've already been introduced. And, I did hear that question from Regina about what a recovery coach is. And so just really briefly about our program, we are a multidisciplinary team, including occupational therapists and nurses, social work, and recreation therapy. And we use the term recovery coach just to sort of describe what we do because we all function in very similar ways with our clients, helping people work on their own recovery journey. So it's an informal title that is a multidisciplinary catch-all for our team's function here. The obligatory disclosure slide, Carrie and Nicole and I are employees of Island Health and are paid for our time, and Doreen is receiving an honorarium from PSR Advanced Practice for contributing her time, but we have no other disclosures. We're not getting any secret kickbacks from Zoom or anything like that. Today we want to overview what our program is and the pilot that we've tried for virtual care. And we'll go through some highlights of the programming planning process, as well as some tips and tricks on virtual group facilitation that our group leaders have learned over the last few months. We'll get that perspective of a person with lived experience who's experienced both our in-person and our virtual groups, and we'll take a look at some client experience survey feedback information and take a brief look forward to potential opportunities for virtual care in the future. So the Mental Wellness Day program is an outpatient adult mental health group therapy service, psychosocial group therapy service in Victoria, BC, operated by Island Health. And And pre-COVID, we had a wide variety of groups, everything from yoga, relaxation training, activity-based groups, very specialized cognitive behavioral therapy groups, recovery-oriented groups, and sometimes as many as 20 people in a room at once. So, obviously mid-March, we had to abruptly stop our programming and sort of start offering individual phone support to folks who had been attending. And then as Island Health was able to create more opportunities for virtual care, we tried a couple of groups virtually. And then as public health opened up a little bit more, we were able to bring people back in person, but in a much more limited way with much fewer people in the room. And so at that point, we developed a hybrid pilot program where we had most of our groups offered in person and virtually. And that program's been running for about 3 months now. So we've had an opportunity to pause and reflect and evaluate how things are going and share the information that we've learned with you all. Now, we have a lot of stuff that we're going to be sharing verbally, and we decided rather than assaulting you with this dense text, we're going to pause on more attractive, visually pleasing slides as we talk, but we have captured everything that we said pretty much in a text slide. I'm going to be skipping right past those text slides, but this will be posted later on the website. So if you want to come back later and review, then that will all be there for you. So the virtual program design steps are pretty much the same steps that you follow for any kind of program design. It started with a needs assessment, and we are very obviously had a need. We weren't able to provide care to as many people as we had before with the new restrictions, so we needed to come up with a way to provide service and reach more people in a creative way. We took a look at best practice and literature review. Then we needed to choose a virtual platform and work out some specific workflows about how do you do this exactly. Clinicians need to develop their competence with a new intervention, and group content had to be adapted or developed to fit with a virtual platform. Then we trialed it, and we're now in the process of evaluating and continuing to iterate and improve that. So thinking about evidence-based program design, of course, we always want to do a lit review, and there isn't a whole lot of literature about especially group-based virtual care. There has been some exploration of individual cognitive behavioral therapy, some indication that virtual individual cognitive behavioral therapy is as effective for mild to moderate depression as in person. But looking at folks who maybe have more severe or persistent challenges in a group-based setting and a variety of different types of groups, there isn't a lot of evidence about that, but there is a body of literature emerging in the context of the COVID-19 pandemic indicating that although there are also challenges with virtual care in this area, there is also a lot of benefit and a lot of potential there, and that we really should be using this, exploring it, and evaluating it further. We also want to look at if there's any best practice guidelines out there, and there actually already was a couple of years ago. The Mental Health Commission of Canada developed an e-mental health toolkit, which it's a broader umbrella than virtual group therapy, but it is a really good general guide to look at when you're trying to offer any kind of e-mental health service to go through that. And also, as soon as the pandemic rolled out, then the Provincial Health Services Authority created a really handy toolkit and website that has a lot of information about virtual care in general, not just mental health. So that's a really good resource as well. We also wanted to think about ethics, and for us, the main considerations that arose were the duty to provide care and equitable access. So, we found ourselves in a position where we were withdrawing care because of the public health orders, and that we needed to be able to offer care to as many people as possible, even with those restrictions in place. We also were mindful of the fact that some people would not be able to access in-person care, not just because of the space restrictions, but because maybe they have some medical comorbidities and vulnerabilities that would make it not a good choice for them to access in-person care, whereas other people don't have the technology available to them, or maybe the technology isn't a platform that meets their needs. So providing a hybrid group service that had in-person option and a virtual care option was a way to provide more care to more people and make it as equitable access as possible to as many people as possible. And then the next thing we needed to do was choose what sort of platform we were going to use. And there's lots and lots of different considerations here, just really high level. Briefly, I'll say that you need to think about the legal considerations, privacy legislation, and that's different for each province. Here in BC, it's the PIPA legislation. And if you're fortunate enough to work for an organization that has a privacy office or a privacy officer, then that person or that department is going to be able to vet and endorse different virtual platforms from a legal perspective. And so we did have that here. Also want to be mindful if your organization has other wraparound policies and guidelines around interacting virtually with folks. So not just that platform, but you probably need to communicate meeting links, for example, via email, via a text message. So, Island Health has those other guidelines and policies, and if your organization has those, you need to be aware of them, or if it doesn't have them, then those need to be developed. Also want to be aware of, do you have the IMIT support for the particular platform that you're using? And finally, does that platform often offer the functionality that you need to do the intervention that you want to do? So here's a list of platforms that are endorsed by Island Health from a privacy perspective, but only one of them provides the functionality of having multiple patients join at once so that you can have group therapy experience. And that's Zoom for Healthcare. So that's the one that we've been using for our program. Also, as regulated health professionals, it's our obligation to make sure we're competent in offering any interventions that we're going to offer, and doing a self-assessment of our competency and developing a professional development plan to fill in any gaps that we might have. And so in a context of technology that's rapidly changing all the time, and a global pandemic that is also, the situation is rapidly changing all the time, it's really important to not only, like we might have in the past have done this kind of self-assessment development plan once a year. Now we need to do that much more frequently to keep up with the changing environment. Also, I think previously in other situations, we might have sought out formal education or a webinar, or found a mentor who had a lot of experience in that area who could mentor us. But in this setting, we're all on the vanguard. We're all learning new things together. And so it's important to do this kind of professional development in a different way. And one model that we find useful is to seek out colleagues who are also learning in this area, and maybe one of you has some information, the other one has some other skill that you've developed, and have this reciprocal mentorship way of doing professional development. And also we want to reach out to look at your professional college and see if they've developed any position papers or guidelines on virtual care. It's also important to take a look at the process of working with your clients and doing the needs assessment part with them to look at virtual care and wrap that in there as well. So needing to be able to understand the pros and the cons and the risks and the benefits and how risks are mitigated, both for in-person in the context of a pandemic as well as for virtual care, and be able to help your client work through those and see how those different options might match the needs that they have, and realize that people change all the time. So that needs assessment needs to be ongoing and revisited because the right fit might change at different times. And one thing that can really help is to have a decision support tool to help clinicians work through those various considerations. There'll often be these kinds of tools created for physical medicine, and it might seem a little more obvious, if someone needs to have an injection, they're going to need to see in person, but in mental health, that might be a little more subtle, and looking at a decision support tool can help you think through those things. We have an example here that you can look at later. I don't really have time to get into all the details, but here's something that we use. And I want to preserve time for my colleagues to speak. So I'll just really very quickly say that privacy and safety is also an important consideration when you're thinking about virtual care, that those things to think about would be different, maybe bring up new risks to be aware of. And there's a lot of those. So just a few examples might be, what if you're doing a virtual visit and you see someone having a medical crisis? How would you respond to that? Or we know that communicating via email is not considered confidential, but you still need to do some communication when you're providing virtual care via email, probably. So how do you do that in a way that preserves privacy considerations and is providing informed consent to your client? But now I want to really turn things over to Carrie and Nicole, who are group leaders. They've been on the ground trying this and offering this over the last several months, and have really learned what the challenges are with offering virtual groups and facilitating virtual groups. And they've come up with some tips and tricks and ideas of things that can help. So I am going to mute myself and let Carrie speak.
Great. Thank you, Lauren. Yeah, I'll just share with you how we as clinicians are able to really kind of get our clients on board. This is something new for them, most of them. Most of them also, they haven't really used technology in this way. But that being said, it wasn't impossible. So what we would do is we would contact our clients prior to our groups joining together. We give them an opportunity to have a bit of a dry run, kind of shake some of those nerves out, practicing them to teach them how to unmute and mute themselves, how to change their names so that it's only their first name that shows up in their box. In addition to that too, we've also given them a little bit of tools to use the chat function in case they need to contact the facilitator and didn't want to interrupt the flow of the group. And that said, these are social norms that we're teaching people. This is brand new ways in how to do groups. Just like you would in walking into a group, you find your chair, you have a little chit chat with each other. This is a different platform, and yet we kind of still hold some of those same norms. We want, people to arrive in on time, give us their undivided attention. And also there's times where we've had worksheets that we would send out earlier. And so if people have those completed, then we can kind of really allow that conversation to be full and rich. But in addition to that too, we also know that there's background noises happening, maybe a dog barking or a doorbell ringing. And so again, we've asked our clients to use their skills in how to figure out how to mute themselves and unmute themselves. And I'll just touch base too on that safety concern that Lauren brought up. So on a practical note, this was really important, and it's a great way to feel that as a clinician, you can hold your client and support them if something comes up unexpected, as you would if they were in person. So what we would do is we'd collect not only their name, their address, but that they'll be calling in from, but their phone number too. In addition to that too, like a neighbor's phone number or an emergency contact who can quickly check in on them if the need arises. And the reason why we did this is we were thinking of those situations that maybe there's an emotional crisis that may occur, like something came up for them, or there might be a physical concern that maybe needs actually additional attention that we actually can't provide from this end, which is possibly calling a mobile crisis team and sending them to that address or even 911. Fortunately, we haven't had that situation occur, but if it ever did, at least we know as clinicians, we know what to do. All right, next slide. Thank you. So now once everyone's in the group, we got them all here. As a facilitator, I'll just share kind of my tips and tricks for you. What we would often do is we would finish our conversation before we let everyone in. And once they're in, we're like, hi, how you doing? Good to see you, Jeff. Welcome, Jane. And we want to call people by name. And the reason why we do this is some of the feedback we would get is that people are like, I'm just like a square on the box, like kind of two-dimensional. No one's really going to notice if I'm there or not. But I feel like when we're able to really, as facilitators, accentuate our nonverbal cues and also really invite people in, then that's where people are able to feel welcome, to know that it's important for them to be there. So for the first 5 minutes, we would kind of just do a gentle check-in question, like an icebreaker question that can kind of get things rolling. It's not too heavy, but it relates to our topic of discussion for that day. And if people show in a little or come in a little bit late from technical difficulties, we're able to also just kind of bring them alongside quite easily. And then that allows us to kind of get then the ball rolling in around that 7-minute mark into our topic. Oh, and one quick tip for you, because you do want to still maintain eye contact with your group or with the participants, my hot tip is take the grid, rise it up to the top where your camera is, and in this way you can still scan your colleagues or your participants, and yet still make it look too like you're able to get good eye contact to them. All right, next slide, please.
Okay, thanks, Carrie. So now, once people are welcomed and settled into the group, we're pretty soon going to want to get discussion rolling. And facilitating interactive group discussions can be challenging in Zoom. You don't have that eye contact or other nonverbal signals to figure out who's speaking next. To help overcome this, some suggestions from our team include unmuting everyone. So this eliminates that dead air effect, that stark silence that can be awkward when speaking to a muted group. Instead, subtle verbal responses can shine through, and discussion can really come alive with those hmms and ahas and laughter. Another tip is for group leaders to explicitly direct traffic conversationally. So this includes calling on people by name, inviting quieter individuals to share their thoughts, and if needed, assigning an order to people who pipe up at the same time. Group leaders can also make connections between what people are saying and link back to the main topic to make the discussion really meaningful. Another type of suggestion is to ask broad, open questions to the whole group and use silence to allow time for a response. We've really been finding that leaving longer silences is necessary in Zoom as people are trying to figure out if they should jump in, when they should jump in, that kind of thing. And here it's really handy to watch closely for body language that someone might want to speak and prompt them by name. Again, being explicit. And also reminding people that they can physically raise their hands if they want to say something, or using the hand wave function in Zoom. Okay, next slide. And another area we've had to experiment with is how to convey the information we're teaching. So if we think about in-person psychoeducational groups, we usually deliver information using several modalities, maybe whiteboards or handouts, PowerPoints or videos. With some creativity, information can still be conveyed in similar ways during virtual groups. We found it really helpful to email materials before and or after sessions. This way, people can print out what they would like and have the handouts ready and save resources for later reference, especially if they need more time to process that information, or if they're having some memory issues, they can go back and refer to that information. Also, the share screen function, I really love the share screen function. You can use this function to share Word documents, PowerPoints, videos, or websites, pretty much anything that's on your screen. In the groups I co-facilitate, so a lot of cognitive behavioral therapy for psychosis groups, we're often sharing our screen to go through the PowerPoint. So exactly the same as we're doing right now in this webinar. And if part of the session is working on individual worksheets, kind of there in your own space, it can be helpful to have participants muted so they can concentrate. So here that stark silence is actually helpful. And don't forget about using real things to display information. So you can always use real world pieces of paper or whiteboards and hold those up to the camera. Okay, and next slide, please. Okay, and no matter what type of you're running, whether it's virtual or in person, one thing is imperative, and that's working together with your co-leader. And this can really be quite a balancing act with so many tasks and so little nonverbal signals to nudge your co-leader with. You really have to be explicit with your plan and your roles. So it's really important to plan in advance which roles each co-leader will play during the session. So who will admit clients from the waiting room, who will lead the check-in question, as Carrie was talking about, who's going to lead the discussion, and who's going to teach which segments, really important. Also, who's going to receive emails, so check their emails and also receive phone calls from people with technical difficulties. And then also who's going to respond to emergencies, really important to decide that. Also helpful is openly telling the group participants which role each leader is playing, like who to send chat messages to and who to contact with technical difficulties. If something unexpected occurs that wasn't planned for and has to be responded to in the moment, our team has found it best to just be bold and step in and address the issue. Then it's important to allow time afterwards to discuss what's happened and debrief with your co-leader. So as much as we'd love to be telepathic here with our co-leads and keep the mechanics of group leading behind the scenes, it's just not possible. So it'll be way more helpful to use explicit verbal cues with each other, like, can I add to what you just said? Or did I miss anything? Or was that question clear? And then here's a real one. So next slide, Lauren, and then Carrie, over to you.
There we go. Thank you, Nicole. And as well, we just wanted to also share with you some of our ideas. Not only did we run like CBT groups or, talk therapy groups, we've actually been able to be a bit creative and run some other stabilization type groups, and also some exposure experience groups that we've also used. So what I'm meaning is that, like, for instance, our let's say like our relaxation group, what we do is not only do we do a bit of the talking and teaching, but we also will do like a mindfulness, and like we were talking about sharing screen, we share a YouTube video, which is a beautiful landscape, nice music, and yet it still allows the facilitator to hear the facilitator as it's running, and that's just through the screen share. In addition to that too, we used games as our stabilization style group for our clients. And how we're able to do that is share screen by using either like Boggle is one of those ones, or there are a couple of other games that you could just find it on the internet and press share screen so everyone has a chance to be able to see the same board game there. In addition to that too, so we use the poll function, and why we use the poll function is that when we're doing some work with clients that maybe are like helping clients like do some exposure therapy or exposure experience, sometimes rather than asking them verbally how did that go for them, we would easily be able to use the poll function, and that gives people the ability to share their experience but yet not feel as vulnerable. And then in addition to that too, we've also played dice games with our clients. And what this did is we would set up a phone, like a separate phone, and use a tripod. And that tripod would also be a participant and a little square on our group. And what that did is it allowed not only the participants but the facilitator to kind of like have that like, oh, should we go a little forward, should we roll again? And it gave a lot of connection between not only the participants but also the facilitator to rally around someone experience like this game that we will be playing with them. So that's why I think like Zoom, we've been able to really push the limits and try some new things with them, rather like more beyond just this talk exchange kind of therapy that we're able to offer. But with that, I'll wrap that up. But I would love to share next that Doreen has been a participant, and she has been able to share such deep and rich, beautiful meaning to what actually it is like to experience this. So I'll hand it over to Doreen.
Thank you.
Sorry, I've got Lauren here, just having a little bit of trouble finding the right button. So I'm going to actually stop sharing this slide and then turn over to Doreen, who is a person with lived experience, to share her understanding and her perspective on virtual as well as in-person groups.
Just want to say it's still, I think I have not come up yet on the screen.
You are up there.
Am I?
Yes,
Oh,
yeah.
I can't see me. Am I up there?
You are. You're the
Okay.
main pinned video. So go ahead and share your story.
Thank you. Yes, my name is Doreen G, and as a past and present participant in various virtual groups in the mental wellness programs, here are my perspectives gleaned from my experience. First of all, the advantages and benefits of the virtual Zoom experience. During COVID, I've been very grateful that I've had that connection through the computer when I felt isolated and very cut off from the world during the pandemic, basically. And this technology has, and I think this technology has a very important place during this kind of global health crisis. Obviously, it allowed me to stay home and keep myself safe and free of COVID. Also, another big advantage to me and benefit is that the great convenience of it. I don't have to get dressed. I don't have to do my hair. Well, I do minimally. Okay, I have to look okay on Zoom, but I don't have to arrange a ride, transportation. It's a huge time saver because I don't have a car, you know. So that's definitely, the convenience is incredible. And also it allows me to access much more programs that are helpful to me. With time saving and the ease of participation, I could attend more groups. So definite advantages. However, for me, the disadvantages of this kind of platform vastly outweighed the advantages. The most difficult thing for me is not having the person I'm dealing with, whether it's a group or whatever, not being physically present. There's no personal face-to-face intimate kind of support. And as a mental health consumer and one person with lived experience, I need that. I need that physical, personal, face-to-face, both people in the room, in-person connection. Also for me, with the virtual format, I missed the valuable social time with the other people in the groups before and after. That's really important to me. And also in the groups, I found that I could relax more if I was able to talk to people beforehand and kind of chat. And I've actually made some wonderful friends through the in-person groups, which is a wonderful side effect of the in-person groups. I found during these Zoom sessions, the virtual sessions, many times I could not hear the other participants, which was frustrating because perhaps the person on the other end was not able to adjust their volume, or they didn't know how to adjust the volume on their computer. You know, it's not their fault. They just didn't have that particular ability. And so I couldn't hear what they were saying, which was frustrating. Now, the downside to convenience that I mentioned before is that as someone who experiences some anxiety when interacting with others, I do not need an easy way to avoid that. I need to push myself to get out of the house, to go out and meet people, and to learn how to manage anxiety. And the virtual format gives me an easy way to avoid that, basically. Now, also Zoom, I found Zoom to be a very distracting medium. First of all the bells and whistles of even using a computer itself is distracting. Then during the meetings, I was looking at people's homes and their furniture, and you know, with the sound on Zoom, someone coughing sounded like an explosion, basically. Their dogs barking, kids yelling. And it was not always possible to mute if we were having an interactive time. It was difficult sometimes for me to focus on the learning. And also due to anxiety, loud, sudden noises do bother me. And next, even though I am very computer savvy, it was still difficult to manage the new technology. One day my computer decided to do a Windows update, you know, right in the middle of a session. So these things you can't plan on beforehand, and this is what happens. So I cannot imagine how other people without any computer skills could even handle this, quite frankly. There's a definite digital divide. I believe, in my opinion, is that the virtual format discriminates against many clients with no computers or access to computers, and those who are too anxious or do not know how to use a computer. And many times during the meetings, I felt out of it. I felt like I was not a part of the Zoom meeting. If I wanted to say something or join the discussion or something I felt strong about or wanted to comment on, I was not able to. It's really difficult to get a feeling of connection in a virtual meeting. So I consider virtual format to be a very limited platform, despite all its benefits. As long as there's no problems, it's fine. But if someone is upset or uncomfortable, it's impossible to deal with that. In my opinion, it's impossible to deal with that through a screen. There seems to be no wiggle room in virtual format to manage any kind of crisis or disruption. So to end, my recommendations and suggestions for people implementing these programs from my personal experience as someone with lived experience is that it has many benefits, but it's very limited in its capacity to help people with mental health issues, I believe. To me, at the very core of helping and supporting people with mental health challenges is that strong, emotionally intimate, personal connection, face-to-face and eye contact. In short, being there for them physically and mentally and emotionally. And they can feel that. They can feel that somebody cares because they're right there. That cannot be done through a screen, in my opinion, whether in a group or individually. My view is that it's not going to be as effective. It'll never be as effective as in person. And even though there are many benefits to the virtual format, nothing replaces that intimate personal connection. And another suggestion is providing training to clients before, so that at least they're computer literate so they can use the program, and to always give people a choice of whether or not they want to use virtual or in person. It should be up to them. And overall, to conclude, the virtual platform is okay as a complementary therapy, but in my opinion, should never be used as a mainstream form of rehabilitation and treatment. Thank you. Thank you for listening.
Thank you very much. I really value your input, Doreen. Thank you for putting a face to that feedback. I'm going to move next into the results of our survey, which is a bunch of graphs, but it's so important to hear and see that story and that experience from a person who's actually lived that. And I think it's a really important point that there may be some benefits, especially in the context of a pandemic, but that virtual care might still not be the best option, even if it does offer some solutions to a difficult situation. I'm going to switch back to the slideshow and share the results of a survey we did with people who are currently attending our virtual groups. And the caveat here, though, is that we surveyed folks who decided that attending Zoom groups was something that they wanted to do. So they at least saw some benefit in trying that. And this is not a survey of everybody, so it doesn't include people who said, this isn't at all going to work for me, or those people who have that digital divide that Doreen spoke to, didn't even have the option to choose it because they don't have access to computers or internet. So we're already surveying people who at least see some benefit and have access. So I'm going to go to the slideshow now. So 31 of our group participants consented to receive the survey link, and 21, so almost 68% of those completed the survey. And of those who responded, most of them, when they looked at the overall experience of receiving group services virtually, were satisfied or extremely satisfied. However, when asked to compare in-person groups to Zoom and how helpful they were, most of them said that Zoom groups were somewhat less helpful or much less helpful than in-person groups. There were a few people, though, that found them about the same, and even a few who found Zoom groups more helpful or much more helpful than in-person groups. That just speaks to the fact that there's variety in terms of what people's needs are and what best fits their needs, but still that preponderance finding in-person groups being more helpful. We dug a little deeper into in terms of what might make Zoom more preferable or less preferable, and not surprisingly, a lot of people found that what made Zoom more preferable was the context of the pandemic and safety around that. And also, much like Doreen said, it really reduces your travel time and the effort to get to group. However, also very much in alignment with what Doreen said, most people felt that the reason Zoom groups were less preferable was that lack of interaction with others during the group and before and after the group, as well as the technical difficulties, but predominantly that social interaction piece being less available via Zoom. We also delved into some nitty-gritty about what each aspect of Zoom group, how easy was that for people to use. And looking at the green here, we found that most people found it somewhat easy or extremely easy, all the different aspects of Zoom, but a few, it's important to realize, had some difficulty or extreme difficulty with the easiness of using Zoom. So we really need to be aware of those people and realize they needed more support, or that this really isn't a good fit and doesn't meet their needs. And so to attend to that. Likewise, we explored different aspects of Zoom that might have been helpful for folks and their mental health management. And most people, despite the fact that in-person groups were more helpful, did find that there was somewhat or extremely helpful. There were some aspects of Zoom groups that were helpful. So that green is showing helpfulness that people perceived. And interestingly, even though the main reason Zoom groups were not as helpful was that lack of interpersonal interaction, most people, the majority of people, did feel somewhat supported and somewhat connected to others. And again, I really want to draw your attention to the few people who found that experience somewhat unhelpful or not at all helpful. So there are still some people here that this is really not a good fit for their needs and not meeting what they need. Finally, a really interesting question. I was surprised by the response. If COVID-19 pandemic were over and we took that out of the picture, how likely would you be to attend groups via Zoom? And there's a wider spread here than I expected. Even though most people would mostly prefer in-person and occasionally Zoom, or would always prefer in-person, there still are a number who would equally prefer either option, and some people who would mostly prefer Zoom or would always prefer Zoom. So that again just speaks to the fact that there's a variety of different people with a variety of different needs, and different options are the best fit for different people at different times. So now is a moment to think about the future and going forward. So it seems clear that in the context of the pandemic that we still want to preserve virtual groups as an option to make services more available to people. And really interestingly, without the pandemic, we probably wouldn't have this opportunity. We've found that bureaucracies and regulations that had been barriers to virtual care in the past were rapidly updated and changed, and roadblocks that were there before were overcome, both in policies and procedures, but also in just access to equipment and software and things like that. So we now have an opportunity to provide care in this way that we wouldn't have had probably, at least not as soon and as quickly, without this having to respond to the pandemic so quickly. And it seems as if going forward that some people at least might have this their care enhanced by having this opportunity available to them. However, based on our client feedback as well as clinician experience, it really doesn't seem like virtual care should replace in-person care, that there are things that you just can't provide virtually that are available in person. And finally, of course, this is an emerging area of research, and we don't know as much as we want to know about how efficacious virtual care is, and what might make it more or less efficacious. So more research, especially in the area of group-based virtual care, would be really valuable. I did see in that some question around our lit review, and we just included some of the main recent emerging literature around pandemic context in a reference slide here, as well as the two best practice guidelines that I mentioned, the Mental Health Commission of Canada and the PHSA. So that's on the final slide there. And also, if people are interested in our local workflow that we created, it's particular to our context, but it does go through some nitty-gritty things like, exactly how do you go about inviting people to a Zoom group and preserving confidentiality over email? Exactly how do you share screen in a way that you're not accidentally sharing something you shouldn't? Exactly how do you go through a checklist to onboard folks to virtual care to make sure you're covering off all the privacy and consent processes that you might want to do. So if anybody's interested in that, you can email me and I'd be happy to share that as well. I'm going to stop sharing screen now and unpin myself so that we're all able to open this up to discussion and question and answer.
Super. Well, on behalf of us all, just want to say a big thanks. I found that a very eloquent presentation and comprehensive from lots of different perspectives. Doreen, such a joy to have you and your perspective. I am a person who likes face-to-face meetings as well, so I get that. And I think your team, Lauren, has just produced for us lots of, pause for thought in terms of just the variance in terms of what different people need and different people want. So we welcome any questions that might come in, and maybe we will start with some things. So thanks for attending to that thing about the literature, the question about the literature. And also there was just a request for any measures and evaluation model that you might have. So there was a request. So I guess it's the same response, Lauren, just shoot you an email, and perhaps that's the best way to that. And also the resource that you shared, Lauren, with PHSA on there. There's also an individual whose job it is to dedicated to support people. So I think you can reach out to PHSA as well. In terms of some of the nitty-gritty questions, there were questions about, are all groups closed or are they open? Are they time limited? So I'm not sure if maybe we could just start there in terms of.
I'd be happy to answer that. So initially, when we were scrambling to figure out what to do, we started offering a couple of open groups to people who had already been in the same open group in person, but only virtually. That was before we were allowed to have in person. And then as we formed our complete hybrid program, we realized that we have a limit how many people we can really serve virtually in a group, because you can't really see everybody at once. So we felt that 8 to 12 would probably be the max we could have in a virtual group, and then we were limited to our in-person because of the size of the room and how many people you can fit in for infection control.
Sorry about
that. So we decided to make our groups closed because we wanted to be able to open. So we have a rolling entry, but a time limit. So people can start whenever there's a spot available, rather than having to wait for a specific start date. But then they have a time limit to make room for somebody else. And then if they want to take it a second time, they would just go to the end of the waiting list to repeat it. So that was our first. We did that for several months. Then we realized that some of our groups, we don't have that many people attend them. So I think people are kind of rolling into a repeat of it right away, rather than having to wait for a bit, because there wasn't a wait list. We did have a few closed groups that were closed previous, because they were modules that built on themselves, and we maintained that closed model for those couple of groups that were closed. So we've mostly, I think the main difference is that some of our open groups have a time limit that didn't have a time limit before.
And I think just to follow up, part of one question was, were there co-facilitators, pardon me.
Were there co-facilitators? Yeah, all of our groups are co-facilitated. We have occasionally run our in-person groups with only a single facilitator there when we were unexpectedly short-staffed, but with somebody on standby for any kind of emergency that might arise. But we found that the virtual groups, we really need to have a co-facilitator because unless it's really, really small, like only a couple, 3 people showing up, because it's really hard to share your screen and teach something and also scan what's going on with all the participants and make sure everybody's okay. So much like the 2 leaders described, I think it was Nicole who described how we'd have an assigned role for each grade. One would be looking at how people are doing, another one would be teaching, for example.
Super, thank you. One person had a request. Any suggestions for the therapist in regard to engaging people or giving the opportunity over these platforms? I'm not sure who might like to take that question.
Sorry.
Oh, go ahead, Doreen.
Yeah, I think that question, was it addressed to me as a one with lived experience? I think it was.
Yeah. Yes, it was Doreen. Yes, Doreen.
Yeah. Thanks. Well, I think a way to have more where people feel more part of the group and more connected to the group, and is to maybe perhaps they could have a check-in when they come into the group, and they perhaps could mute everybody except the person speaking and give the person enough time to say what they have to say. And then each person gets a time where they're not going to be interrupted, where everybody else is muted, and they can tell people how they're feeling, and if they're feeling nervous or anxious, to say it and tell the group. And then during the Zoom meeting, I know in one Zoom meeting I was in one group, somebody actually had a separate room where people could go to talk with one of there. It was like a break room. They could click on Zoom where they could do a one-to-one with somebody. That's really important to have that. I actually couldn't figure out how to use it. I need a bit of training in that to even use it, but that's one option. And also during the meeting, if somebody's having a hard time for whatever reason, if they put up their hand, maybe the facilitator can maybe say, excuse me, could everybody please mute yourselves, and I would like to talk to this person individually. Sorry for the disruption, but we need, I really would like to be able to deal with this. So at the end of the Zoom meeting, encourage people to share how they felt, and a checkout time at the end where they are where each person has the floor as before. But I think if I was a facilitator in this kind of meeting that I'm recommending, I would say beginning, if anybody's having any kind of trouble here, anybody's anxious or uncomfortable, or you're feeling really upset for whatever reason, please put up your hand, and I will try to deal with you on an individual basis during the group, or else we can talk after the group for 10 minutes. But make sure that people are not kind of stuck, if they're feeling upset, they're not stuck there, to give them an opportunity to get some help.
I see. Thank you. Yes, thank you. So
I don't know if Nicole or Carrie want to comment on that at all. I know that there is individual follow-up via phone oftentimes, but I'll hand it over to the group leaders if you have anything to add to that.
Yeah, I guess I usually get email from my group participants. I work a lot with the younger adults and the early psychosis population, and they're pretty tech savvy, and so I get emails in that I respond to and then follow up. Usually the ask is for follow up after the group, so that's what's typical on my end. I'm sure about you, Carrie.
Yeah, and the population I've served was kind of around 50 plus. And with that, we haven't used breakout rooms just to add that extra layer of like complexity to the technology. So what it is we've actually just says, I'll give you a call as soon as we're done. And so this is a conversation that we can debrief.
Thank you. Nicole, there was one follow-up question that might be just for you, and it was asking if you feel equally maybe uncomfortable on the virtual platform. I don't know if you have.
Yeah, that's a really great question. I think it depends on the individual. I'm finding with this younger population that they're more tech savvy, which is great, but still really appreciating the in-person groups and realizing how important those are, those in-person interactions. And a lot of them as well are spending quite a bit of time online anyways, like for school. And so they're growing a little tired of the screen time. So yeah, I'm finding that they're wanting also to come into group because of that. But still, that said, yeah, the virtual setting, people are attending the group, and they say they're getting something from it. So yeah, definitely still something learned from that.
Yeah. Thank you. Thank you. I think we all experience a little zoom out after too many Zooms for sure. So this Carrie mentions about wrapping up a DBT group and asks for a little advice in terms of removing themselves from the group context, so group members have opportunity to connect and exchange ideas or connections or whatever, and asks what do we think of this?
I can answer that because we did explore that a little bit with the professional practice and privacy here at Island Health. So traditionally people would come to groups and, they would casually interact in waiting rooms and connect and maybe even exchange contact information and meet outside of the group. And with Zoom, that opportunity no longer existed. So we wanted to see if there was a way to provide that, still taking into account, confidentiality and privacy concerns that might be there. And also in different practice contexts, there are different kind of what you might call group norms. And so there might be some programs or groups where that social connection outside a group is, totally fine and encouraged or not really addressed. There might be other practice contexts though where the group norms that are established are that you really come there for therapy, and that you preserve that space and that time for therapy, and that you don't interact with other participants socially. And that's really a difference in what you might call a point of care risk assessment, depending on where you're working and what kind of people are there and what they're there for. So we had those two things. So one is taking into account the point of care risk assessment for that activity and whether there would be some reason why that would not be a group norm that people would interact. And I think that really is not so much a concern here, but I think in some settings, people might say, hey, we're working with people who are particularly vulnerable, and we could be putting them at risk by saying having an unsupervised social interaction where there could be, who knows what kind of predatory thing might occur or something, and we feel responsible for that. So I just encourage that wherever you are and wherever you're working, that you take that into account. On the other hand, the other part is the confidentiality and privacy piece. And so our understanding from speaking to professional practices, as long as everybody understands and consents to it, then they could choose to participate in that. So we would say, we're going to preserve this 10 minutes into the group for people to interact informally, socially. It's 100% optional. It's not going to impact your ability to receive care if you decline or you accept that opportunity. And you can say yes or no. And we want to make people aware that, that it's their choice and that they consent. And then you document that people consent to doing that and provide that opportunity.
Thank you. So I guess that adds a little bit to the next question, which asks Doreen to comment on if 15 minutes at the beginning or the end for social chat, if that would be a helpful strategy.
I think it would, but I just want to kind of say that I was in, well, I experienced in one group that I was in, it's really tricky to do that, because on Zoom, it seems as though people's voices are really pronounced and they're quite loud sometimes. And if you get a lot of people talking at once, it can get really, really loud. So it would have to be really carefully done, because for instance, if you want to have it like a group, kind of a social chat or something, you'd have to do it like with you'd have to make only one person is talking at a time and not everybody at once, because it gets very loud and very confusing. So one person talking at one time and everybody muting themselves, and then the next person. So everybody gets a chance to talk, but nobody has a chance to kind of to talk over them, because in a regular conversation you can do that, but in Zoom it's awful, because you get like this explosion of noise. So that would be, I think it would be a really helpful thing to do before and after, but it would have to be carefully monitored so that everybody has a chance to talk. Yeah.
Mm-hmm. Thank you. So you really asked for the moderation so people don't clang into each other. And
yeah, right. Yeah.
So Kathy asks, we've invited participants to stick around at the end, and we'll move people in and out of waiting rooms so they can book follow-up times after the group. That's great. Yeah. And Lauren adds her email as per the earlier request. Thank you for that, Lauren. Yeah. Have I missed anything at all? Oops.
I see a question from a rec therapist. I'd be happy to answer that.
Thank you.
Yeah.
I did miss that.
So we have one rec therapist who also works on the inpatient unit. So not all of our activity-based groups are run by the rec therapist, although they have been maybe co-designed. So previous sort of more rec therapy style groups that were run before, included a strength training group in the local rec center, a power walking group around the local track, yoga groups that we had yoga volunteers running, and then we also do an activity-based group, which was the card and game playing group. So we did have to stop the gym and the power walking group at the beginning, and our rec therapist sent around some things you could do on your own, body exercise, weight exercises or things in your own home, but didn't lead a group because her time was needed on the inpatient unit. We did pivot one of our yoga sessions to a virtual session led by a volunteer yoga instructor and co-facilitated with the rec therapist. And then we did adapt our game-based group as Carrie described. We figured out what groups, what games we could do this way. And so Google and Yahtzee and Farkle, which are both dice games, were ones that we were running. We hand delivered a set of dice to everybody and projected the boggle onto the screen. Am I forgetting anything, Nicole and Carrie?
It's very creative.
No, I don't think so.
No. Very creative. Yeah. I just want to come back to Hazel, who reached out and just offered her resources and support to anybody who might benefit from that. I just want to acknowledge that. Yeah. And it sounds like you too, Hazel, are offering a wide range of different kind of group, peer-led, family support, and new RAP, wellness reaction planning coming up. Well done, it's great. So it seems that this hybrid approach seems to be taking off, seems to be a big part of practice. So Doreen's caution is so valuable, I think, as we move forward, to consider that maybe it's not for everybody, and maybe there are ways to make it more engaging and tolerable in a way. I heard too, Doreen, you just mentioned
Definitely,
the sound, and yeah, that's. So Hazel asked, is the prom being used?
So in general, the prom is recommended in our system. We don't use it in a mandatory way in the Mental Wellness Day program. Some groups have done it as a group. And I think also in the system, Victoria Mental Health Center included, some individual work is done with that, but it's not being used as an outcome measure. And in terms of I think there was a question about how we're evaluating the hybrid group program. So the satisfaction survey was the main outcome measure. And then the other thing we're doing is looking at how people are voting with their feet or their virtual feet. See which groups, virtually or in person, are preferred and what our wait lists are like, so we can adjust what we're offering to meet what the apparent need is.
I'm just so impressed at the wide range of offerings in terms of just the specific activities. I think I interrupted somebody. I'm so sorry.
Oh yeah, I didn't know where I could kind of say this, but could I please ask what Hazel Meredith said about prom? What exactly is prom?
Oh, sure.
I can explain that. It's a tool that a person would complete for themselves, like a client, that is a way of assessing for yourself where you're at on your recovery journey. And it gives you a number score, but the idea is that it also kind of helps you focus on what you want to work on. So it could be something you work on with your therapist to see, where am I focused on my recovery journey right now? But it could also be something that a whole program uses as program planning. Like if we see 80 of our clients are saying this is one area they want to work on, then maybe we need a program focus that addresses that need. It can also be an outcome measure, though, if you see how the score changes over time. For an individual, they can say, oh, I've made some changes. Or for if you took everybody and averaged it all together, you could say, oh, everybody in this program is moving higher on the scale. I don't like to say higher because it's not a linear thing that you only go one direction on all the time. But it could be a way of kind of saying some indication that people are getting some assistance or some help for what they want from that program.
Thank you, Lauren.
I haven't seen this, maybe others have, but I think that we have a lot of literature around caring for the self as a caregiver and a recipient of care. But I've been doing a fair bit of research recently online, and I find it rather, it's quite intense. I find I'm a little bit more tired than usual after using that platform. Maybe that's just me and my old age. But I'm just curious. It would be nice to see, I think, some work around caring for oneself on this platform. So Doreen, I think you very eloquently shared from your perspective that, you know, the noise, one might be sensitive to that, that the access, sometimes it's bothersome. And then we have these updates and the computer just has a furry fit someday and we have no control over that. But it would be nice, I think, to just be able to have some little health checks for people providing service online. It's different, it's more intimate, it's more intense, I find sometimes, maintaining the eye contact, I find it's different.
I'd really like to hear Nicole and Carrie's input on that, but I can say as a program coordinator, I've been hearing from a lot of staff, they really miss, we used to gather together and have lunch together, and that was a time to debrief and support each other. And that's been lost largely. And we're much more fragmented, even when we're in the same building, like Nicole and Carrie and I are right now. We're probably not really going to see each other face to face. And there is this Zoom fatigue that clinicians experience. One thing I tried early on for this need to connect, for clinicians to connect, was to offer a Zoom lunch meeting, and really nobody wanted to do that. You know, they're like, everybody needs to stand up and go outside and go for a walk. Unfortunately, that's by themselves, and a lot of people would have preferred to have a social connection at that time, but that's what their bodies and minds needed. I don't know, Nicole and Carrie, if you have any tips or ideas about how the self-care aspect from a clinician point of view.
Yeah, so important. Self-care. So also as an OT, thinking about ergonomics, making sure the setup is adequate and supporting our bodies, because I'm noticing, in a day, there's a lot more screen time now. And I'm just itching for those movement breaks and moving my body. And that goes for anyone, clients and clinicians alike. So just being aware of how much time we're spending on the computer, on screens, and connecting with people, so important. I miss that. Yeah. Carrie, what do you think?
Yeah. One hot tip that I've enjoyed I've figured out is I have other glasses. I have computer glasses, I call them, and it actually filters out the blue light, and that actually really helps with any, just sometimes you get fatigued and you get headaches. And like Nicole and Lauren mentioned, our bodies are made to move. As a nurse, I was on the floor, and this is much different. And so I really appreciate it's even if you only have that 5 minutes or 10 minutes in between groups that you're running, just get out there, go fill up your water bottle in the furthest place that you can go to, and then, do the stretches as you walk back, and just take care of your physical body, because as well, this is also mentally taxing. So
I was saying to the team that I did a conference on the weekend and about virtual health, and they had some very similar things to say that this team is saying today, which is really cool. But they left us with this idea that it's pretty new and young for all of us, and that it takes time to just accommodate a new approach and to be kind to ourselves, which I think is a nice and important message in these times. We're all just learning how to do it as best we can.
I want to say how to the Lauren and Regina and Nicole and Carrie, how much I appreciate this opportunity to do this. It's been great for me, but mainly it's just it's wonderful chance to give the client's view of things, and I think the client's views are really important, and it's good to know that they're being incorporated into you know, the assessment of this virtual platform. Thanks.
I'm sure Lauren has things to say, but I will say that from a learning perspective, I think evidence-based practice is not just about, you know, the best of the best evidence and high sophisticated trials, but it's also really understanding how that work lands in everyday practice and how people whose needs we're there to serve, how it lands for them. So that's a vital piece of the knowledge and the wisdom as we go forward. So we really thank you for your time, and you clearly thought about it and some good critical feedback for us to learn and grow from. So that's the deal, isn't it?
Yeah. Thanks, Regina. You're welcome.
And I just want to echo that, Doreen. I think your contribution to this presentation has been probably the most valuable part of it, because the reason we're doing this is to try and serve people's needs best, and we can maybe guess and try and figure that out, but hearing from people directly is the best way to know whether that's working or not, and what's helping and what isn't helping.
Oh, thank you.
So it's 11:52 our time here, and maybe we'll just, I don't see any new questions coming in, but lovely to see that somebody's here all the way from Nanaimo, and terrific to have representation from Island Health. I know that you're doing amazing work, so really helpful to get a glimpse into some of your great new things and things that you're doing. So yeah, we have seen many accolades and many thanks on the chat box saying thank you very much. And somebody from Barrie, Ontario, that's awesome, thank you. And Sydney, Nova Scotia, oh my word, how fun is that? Yeah, so thank you for your head and your heart today. Thank you very much. For those of you who are regular participants, we welcome you back, and we look forward to seeing you very soon again. Oh gosh, before you go, I'm just going to do one thing, and that is just send you a link to to our evaluation, and I'm just going to cut and paste this here. So if you can just hang on tight for 1 second, and please give us some feedback. Tell us how we did today. Why aren't you going in there? No, I don't know why it won't let us. I think we will have to send you an email after the fact, because for some reason I'm trying to cut and paste into the chat box and it's not letting me do that. I want to try one more thing. Command copy, Command V. No, it won't let me do that. I don't honestly know why, but we will send you an email just to ask for your feedback, please. Thank you, Kylie. Yeah, and we look forward to next steps. Bye for now. Have a lovely afternoon. Be safe, be warm. And thanks again, Jean. Thank you very much.